Hello and welcome. My name is Alex Poppin, PharmD, and I'm here to do a quick review of biostatistics relevant to analyzing and interpreting trial data. I've put this together because the topic of biostats is very intimidating to both students and professionals, but being able to wield a base understanding of the subject is a valuable skill in regards to practicing evidence-based medicine. Please note that this is not meant to be a comprehensive review. Biostatistics is a very complex subject, and I am by no means an expert. But I do feel confident that the topics we'll be reviewing today will be the most useful and relevant to you in practice. So let's start by diving into some key terms and definitions. Power is the ability of a trial to detect a statistically significant difference between treatment groups when a difference truly exists. The higher the power, the higher the quality of the trial. And basically, this means that the higher the power, the less likely it is to commit type 2 errors, aka false negatives. And overall, this would increase the reliability of said trial results. Another way of putting this is that a trial with 90% power means that there is a 90% probability that the difference between the two groups is not due to chance. It also means that there is a 10% chance for showing no difference between groups when a difference truly exists. Again, a false negative. When interpreting trial results, it's important to consider whether or not the criteria for power was met. If power is set at 90%, but the criteria for achieving it is not met, then this can greatly impact the reliability of the results, as well as how those results are interpreted. For example, if power is set but not met, and there is no significant difference between treatment groups, the results should be considered inconclusive, and this is because the trial lacked power to confirm that the results were not due to chance alone. Put simply, when this happens, we're unable to be certain if the results observed are due to chance or due to the intervention, and for that reason, the results cannot be relied on in any meaningful way. If power is not met, but a statistically significant difference is observed, this is less of a concern, because a significant difference was detected despite having low power, and for this reason we can rely on said results to a greater extent. P-value is the probability that the observed difference between two groups is due to chance alone. Now it may sound similar to power, but there are several differences that are important to understand. If we look at the definitions side by side, it becomes more clear. Power is the ability of a trial as a whole to detect differences that truly exist, whereas p-value is the probability that the observed difference between two groups for a specific outcome is due to chance alone. But what do we do with p-value, and how do we assess and interpret it? The p-value must be interpreted relative to the level of significance, aka alpha. Alpha is the chance that the investigators are willing to take that the observed results were due to chance alone, and this is typically set at 5%. If the p-value is less than alpha, then the outcome or result is considered statistically significant because the probability that the result was due to chance alone is less than the accepted risk. Next up will be hazard ratios and confidence intervals. These are commonly reported together, so it's important to understand what they mean in relation to one another, as well as how to interpret them appropriately. Hazard ratio is the probability of an event occurring in the active group compared to the control group. Hazard ratio less than 1 indicates lower probability, greater than 1 indicates higher probability, and a hazard ratio equal to 1 indicates no treatment difference between groups. The counterpart to the hazard ratio is the confidence interval. Confidence intervals are a little bit more confusing and easily misinterpreted, but the key takeaway is that the confidence interval is the range of values in which the true value for an outcome resides, and it helps to demonstrate the precision of the hazard ratio. What this means is that for a 95% confidence interval, that if the trial is repeated with the same population, then approximately 95% of the intervals would contain the true value of an outcome. Now, in reality, we don't have the ability to repeat multi-year trials with the exact same population. This is just simply not feasible, but it's an important distinction to note when interpreting confidence intervals. What a confidence interval does not indicate is a 95% chance that the true value is included in a single interval. We can only be 100% sure that the true value is either inside or outside an interval. There's no way to assess the probability for a single given interval. This graphic here helps describe it better. As you can see, 20 confidence intervals are included, with 19 of them including the true value for the measurement, aka a 95% probability. The range and average value for each varies notably, which is why it's important to understand that the 95% value for confidence intervals refers to repeated trials and not a 95% probability for a single trial. But again, we can't repeat trials over and over again, so we must be able to effectively interpret the given confidence interval when reading trial results. A wide confidence interval indicates a less precise estimate, and a narrow confidence interval indicates a more precise estimate. Regarding hazard ratios, if the confidence interval for an outcome includes the value of 1, then the difference cannot be considered statistically significant. And this is because all values reported in the interval range are considered equally valid as the true value, and a hazard ratio of 1 equates to no treatment difference. Another way of putting this is using this example of a hazard ratio of 0.78 with a 95% confidence interval of 0.57 to 1.02 and a p-value of less than 0.05. So both the hazard ratio and p-values suggest a statistically lower risk for one group over the other. However, the confidence interval contains the value of 1, and for that reason, a statistically significant difference between the two groups cannot be claimed. Moving on to non-inferiority trials, these are designed to assess if the active treatment is no worse than the control treatment by a predetermined margin. The predetermined margin is called the non-inferiority margin, aka NI margin. For example, an NI margin of 1.30 means that in order to claim non-inferiority, the upper limit of the hazard ratio confidence interval must not include the value of 1.30. If the confidence interval crosses or touches the NI margin, then non-inferiority cannot be claimed. Non-inferiority trials cannot be used to claim superiority without predetermined testing, and likewise, superiority trials cannot be used to claim non-inferiority. So for analysis populations, there are three main ones: intent to treat, modified intent to treat, and per protocol. The intent to treat population is the sample of patients that simply underwent randomization into the trial. The modified intent to treat population is the sample of patients that underwent randomization and met one or more qualifying criteria. And typically this is taking one or more doses of study medication and is most commonly used for safety analyses. The per protocol population is the sample of patients that successfully completed the trial. And in terms of how to kind of think about these, the intent to treat population will always be the largest in number, followed by modified intent to treat, and then third would be per protocol, since usually there's a decent amount of patients that drop out, so that number will overall be smaller. And while there is no one perfect analysis population to look for, it's just important to understand which one's being used and what that may mean for interpreting the trial results. Composite outcomes are a combination of outcomes reported for a single measure of effect. A common one that we see very often is major adverse cardiovascular events, or MACE, and this is typically a composite of cardiovascular death, myocardial infarction, or stroke. Ideally, each component should occur at similar rates and have a similar clinical significance. For example, it would not be appropriate to have a composite outcome of death and minor bleeding, since that has vastly different clinical significance. Interpreting composite results can be tricky. If a trial reports a significant reduction in the composite outcome of cardiovascular death, MI, and stroke, it's important to understand that this is not the same as demonstrating a significant reduction for each individual component. For that reason, the individual rates for each individual component of the composite outcome needs to be assessed to determine if the overall reduction was driven largely or entirely by one single component, or in many cases, none. Oftentimes, no individual component is significantly different between treatment groups. However, when reported all together as a composite outcome, a statistically significant difference is demonstrated. Relative risk reduction is the difference in event rate of the active treatment group relative to the control group. And as an equation, this is calculated using 1 minus the rate of the active group divided by the rate of the control group. And while this might seem to be the same thing as hazard ratio, it's not. Hazard ratios are derived from regression modeling and can reference a specific time interval within a trial. Relative risk reduction, on the other hand, is calculated using that simple equation and refers to the cumulative risk for the entire trial. And so while they sound very similar, they are in fact different. Relative risk reduction is commonly reported for treatment effect. However, it's easily misinterpreted and tends to overestimate the actual treatment benefit. For example, if the event rate of group A is 10% and the event rate for group B is 20%, we can calculate a relative risk reduction of 50%, which sounds very promising. However, there's only a 10% absolute difference. So anytime that the risk reduction for a trial sounds too good to be true, look to see if it's a relative or absolute risk reduction. And more often than not, you'll find it's going to be the relative. Absolute risk reduction, on the other hand, is the absolute difference in event rates between two treatment groups. This one is less commonly reported than relative risk reduction, but I prefer it personally to relative. I find it easier to interpret, plus it can be used to calculate the number needed to treat and number needed to harm. The number needed to treat is an estimate of how many patients would need to receive active treatment to prevent one outcome compared to the control treatment. This is calculated by dividing 1 by the absolute risk reduction, and in this case, the absolute risk reduction is input as a decimal value and not a percentage, and it's important to remember to round up your value for N and T to the nearest whole number. It's important to note that the number needed to treat is a quick and easy estimate for illustrating the magnitude of treatment effect in addition to the absolute risk reduction. Number needed to harm is the estimate of how many patients would need to receive active treatment for one adverse outcome to occur compared to the control group. And it's calculated the exact same way as number needed to treat, but number needed to harm, the value is rounded down to the nearest whole number instead of up. When interpreting number needed to treat and number needed to harm, it's important to always remember that these are simply estimates used to illustrate the magnitude of treatment effect in terms of patients instead of percentages. Additionally, number needed to treat can also be used to weigh benefit-risk ratio. For example, a number needed to treat less than the number needed to harm would indicate a favorable benefit-risk ratio. However, the clinical significance of each outcome must be considered, and the duration of the trial must also be taken into consideration. This is because that when interpreting the number needed to treat and number needed to harm values, a shorter or longer trial can impact the clinical significance of the observed treatment effect. Additionally, it's important to only calculate number needed to treat and number needed to harm for statistically significant differences. The last part of this review deals with classifying the quality of the trials as well as your own recommendations. Level of evidence, for example, is the measure of the quality of evidence from a trial. Level 1 is randomized controlled trials that meet their power criteria. Level 2 is another randomized controlled trial where power is set but not met. And then levels 3 through 5 are observational trials with or without a control group. Grade of recommendation is an extension of the level of evidence. Quality trials should yield quality recommendations. So a level 1 trial should yield a grade A recommendation, level 2, grade B, and levels 3 through 5, grade C. However, it's important to note that these are subjective measures used to rate the strength of your own recommendation. So you can increase or decrease the grade of recommendation as you see fit, but it should be carefully justified. So what's the purpose of all this? Can't we just read the abstract for trials and be done with it? I'm a healthcare worker, I'm not a statistician. What are we wasting our time here with this? And I would respond that it's important for that healthcare professionals have a basic understanding of biostatistics for several reasons. First, reading the trial abstract is not a sufficient substitute for reading the full trial and reviewing said results. Second, when you actually read and understand the trial, oftentimes you're going to come across things that make the investigator's claims or conclusions much less compelling. However, the most important reason, in my opinion, to have a base understanding of biostats is that it enables you to effectively analyze and interpret trial results in order to create high-quality, evidence-based recommendations to improve patient outcomes. Thank you again for listening. I used several great resources to form this review, and I'll list them below whenever possible. Please refer to them for a more thorough and comprehensive review on the subject of biostats. And if you liked this review and would like to get the slide set, please visit www.highpoweredmedicine.com and create an account. From there, you'll be able to download the slide set, the audio-video recording, as well as 10 free trial reviews from the second edition of High Powered Medicine Landmark Clinical Trial Reviews. Thank you again for listening, and have a great rest of your day.